Welcome to Resilient Waters, Healing in the 10,000 Lakes. I'm Amy. Let's get connected. Today I am thrilled to introduce you to Dr. Stephen Manlove. Stephen Manlove, MD, is one of the most entrepreneurial psychiatrists in the upper Midwest. Dr. Manlove graduated from the University of Minnesota Medical School and completed residencies in psychiatry and internal medicine through the University of Virginia Medical School. He holds multiple board certifications in psychiatry, neurology, internal medicine, and forensic psychiatry. This deep understanding of medicine gives him a unique ability to practice truly holistic psychiatry, fusing lifestyle changes and brain health best practices with genetic testing and a detailed laboratory workup to develop a personalized plan for each patient. As an early adopter of Transcranial Magnetic Stimulation, TMS, and ketamine, or Spravato, he and the Manlove Brain-Body team have helped thousands of patients suffering from treatment-resistant depression, anxiety, and PTSD. Hi, Dr. Manlove. Thank you so much for joining us today.
Well, thank you. I'm pleased to be here. Thank you for inviting me. I appreciate it.
Yeah, this podcast is really just connecting people to resources. And as I've talked to you before, I'm very excited about this resource for people. I think it's the biggest thing up and coming to watch as far as new therapies for psychiatric, really. Now, can you tell me a little bit about what brought you into TMS specifically?
Sure. My background, I'm a psychiatrist and an internist and also a forensic psychiatrist. But in my professional life, I've spent most of my time doing psychiatry. And I've done fairly bread and butter psychiatry. I practiced for 35 years and done 27 years of inpatient psychiatry and 35 years of outpatient psychiatry. And for many of those years, I did fairly regular psychiatric kinds of care, doing assessments, determining if a medication would be helpful or helping develop a treatment plan, and then treating people with medications or psychotherapy.
Yeah.
Around 2014, 2015, I decided I wanted to do something different. I'd been, inpatient psychiatry had been changing. It became fairly ultra short term kind of crisis intervention, which is great. And I appreciate that people are doing that, but it wasn't what I wanted to do at that point. I wanted to do more extended treatments of people. So I decided to stop doing hospital work. And then I tried to decide to figure out what should I do with my life, by the proverbial midlife crisis. And began to think about all kinds of things, and finally decided what I really wanted to do was to do psychiatry still. I thought about, going to law school, becoming a rancher, just retiring, doing nothing. But ultimately realized that for me, the greatest enjoyment I've had has been treating people in a psychiatric setting. It's been really a lot of fun for me throughout my life. But what to do with that? So then I began to consider what would make it more fun. And I decided I wanted to treat people with treatment-resistant psychiatric illnesses.
Mm-hmm.
And at that time, there were some options that were coming online for treatment-resistant depression and anxiety in particular. There are other treatment-resistant psychiatric illnesses, but those were the ones that there was sort of the newest stuff coming out. And the biggest treatments that were being talked about at that time were transcranial magnetic stimulation and then ketamine infusion therapy. So I thought, okay, I'm going to start doing transcranial magnetic stimulation. So I got a machine and began doing that in about 2014 or so. I began just treating patients who I'd seen for years who had never responded to anything that I had done, and found that I was getting some really good responses. So I found that in that group of people who were not responding to medications, and just so you know, if you don't already, about 30% of people with depression and anxiety do not respond to medications that we prescribe.
That is a very high percentage of people. And I know that there's going to be people listening to this who are like, yep, I fit this category. And it is not an easy road.
It's very difficult, and it's a tragic situation. And they were all in my office, it turned out, it seems like. And they do kind of end up in psychiatric offices. Right. So we started treating those people, and we had what I thought was a fabulous response. And that group of people who would have a less than 5% chance of responding to a different medication, we were having about a 70 or 80% excellent response rate. So just a fabulous response rate.
Wow.
So I began to wonder about what might enhance that response rate, what might augment it. One thing that I noticed by serendipity it was an observation that was not a scientific observation, but just an observation that it appeared that people who were exercising contemporaneously with the treatment seemed to do a little bit better. And so I began to do some research on exercise physiology and how that might affect the brain, and could it be augmenting the TMS. It turns out that exercise increases a hormone in your brain called brain-derived neurotrophic factor. Brain-derived from your brain, neurotrophic meaning neuron growth. Trophic means growth. So brain-derived from your brain, causing brain growth. So I thought, oh, that makes sense. And then in further research found that TMS, one of the things that it does is also increase brain-derived neurotrophic factor. And so maybe there was a augmentation, maybe they were synergistic in their effects. So we began to study that, and I began to look at other variables that might increase the response to TMS or other treatments. And most of the literature was in the dementia literature. Most of the bench research was in the dementia literature. And I found a whole bunch of variables that were measurable in blood tests and that kind of thing that might affect brain growth or the neuroplasticity, the ability for the brain to change and be dynamic.
Right.
And we found that there were many, many variables that, if they were off, might affect that. So I began to do huge lab tests with people, looking for those variables, and found in the next 100 people I tested, we had about almost the average person had 5 to 10 abnormalities in that lab work.
Wow. And
so we began to think, okay, let's do what we can do to affect those things as well as do TMS. And so, for instance, people might have a thyroid problem or some kind of hormonal abnormality, or they might have a metabolic abnormality, or they might have increased inflammation in their body, or they might have abnormal, like low zinc level or other mineral levels. So we checked all those variables. And when we did things to impact those variables, whether it be just giving a supplement or giving a medication or doing a lifestyle change, when we did that, plus did basic lifestyle interventions like exercise, diet, meditation, socialization, and sleep, we thought we were seeing a fabulous result. So when we put the numbers together, what we found was that we were having about a maybe 5 or 10% better than the average TMS clinic in our response rate, in our excellent response rate. But what was really, really exciting to me was that in the average TMS clinic, the relapse rate is around 50% per year.
Okay.
In our clinic, it was around 10% per year.
Wow.
So that is a huge difference in medicine.
Yeah.
And so at that point, I was just practicing out of Rapid City. And I thought, I think we got something kind of special going on here. This is really, really cool and really exciting. And boy, the patients loved it. The people who, I'd been working with for years and who had been having no success, with me or other people were having great success. And then they weren't relapsing. I mean, we still had some relapses, but it was not nearly as much.
Right.
So, at that point I thought, well, okay, this is important and maybe we need to do something more with this. So I thought, well, we should do this in a bigger venue. So we looked around and I tried to figure out a good place to go to open up another clinic. And this was right before the pandemic, by the way. So
No stress there.
we were thinking, yeah, we'll go. I decided to open another clinic in Minneapolis. And because I'm originally from Eden Prairie and I went to St. Olaf College and the University of Minnesota Medical School. And, I've got lots of friends there. I've got my own family living in the Twin Cities. It's an easy place to be. And it's only an hour flight from Rapid City. So it's very easy to get to Minneapolis from Rapid City.
Awesome.
So we began to talk about opening a clinic, and I tried to find a psychiatrist in Minneapolis who'd be interested in working with me. And after a lot of searching, found a guy named Brian Johns, who was a psychiatrist who had done a lot of research in ketamine, and he was on fire about doing new things. And so we were synergistic and decided to put it together and put a clinic together. Well, then COVID struck, and I hit the brakes. And then I think it was the COVID was in 2020 that it started. Yeah. So in the summer of 2020, about June, Brian contacted me again and he said, hey, maybe we should be thinking about if we should do this still. We think we're going to find a vaccine. The pandemic's going to move through. Let's start planning. So we planned it all by Zoom.
Yeah.
Now, mind you, neither one of us had ever used Zoom before, but we did all of our planning by Zoom, and we met weekly and put together staff and opened up our clinic. And it was in Minnetonka then on April of 2021. And, we opened it up. 2 weeks later, we doubled our size. A year later, we doubled our size again. Now we have moved to we're in Golden Valley, but basically doing treatment-resistant depression using cutting-edge tools to do that. And TMS is one of them. The other thing that we do is ketamine, and we do Spravato, and we also do vagal nerve stimulation, which is another entity that's really, really helpful for some people with treatment-resistant depression. And we do general psychiatry too. We do all the normal stuff and psychotherapy and stuff like that.
Yeah, I was looking at the website, which I will go ahead and link down below in the description for today's podcast for sure on how to connect with you guys. But it said something about like holistic psychiatry, which it sounds like this is a very different experience than maybe other people have gotten elsewhere. You're really looking at the individual and what's going to fit best for that particular circumstance, whether it's Spravato or ketamine or VNS or TMS. You're looking at the whole person. You're looking at nutrition and diet. You're looking at what other interventions are going to make this successful. I think that is what people are needing. I think, I can see why you're having success.
Well, let me kind of add to that. When I treat people using regular psychiatric strategies, I'm treating their symptoms.
Yeah.
And that's good, but I'm not treating the cause of their illness. When we treat people with TMS and ketamine, we're treating their symptoms also.
Yeah.
We're not treating the cause of their illness. And I think it's important to understand that. If we want to have long-term effects on people, we need to do more than that.
Yeah.
So we need to look and see if there are biological variables that might make them more predisposed, or psychological variables, interpersonal dynamics or family issues or things like that might make them it might make it more difficult to treat them, or lifestyle issues. So we we want to treat at least as much as possible the source of the problem, and we would think by doing this, if we look at a person's whole biological situation, their psychological situation, their social situation, and develop a personalized approach, also their genetic situation, another thing we look at, we think that we can do better than just treating symptoms.
Yeah.
And that's what Advanced Brain and Body Clinic is all about. That is why we are here, why we exist. That is our purpose, is to treat. We want to treat symptoms,
Yeah.
and have the depression get better, but we want to treat more than that if we can.
I love this so much because, and it sounds like this isn't the first time you've done this in your career, but definitely pushing to advance mental health services in general. Like, how can we keep moving forward? Because yes, we want relief for people. We want them to manage their symptoms differently or to be able to manage those. And also that how can we make sure that this continues and that we can prevent and understand that better for the future too. And that really is a huge piece that has been very difficult, I think, when we just looked at symptomology.
Yeah, I want to tell you a story. I had a patient, so I was doing this for a while, and I thought, well, this, for people with treatment-resistant depression, it makes sense to dig deeper.
Yeah.
They haven't responded, so let's do a full court press, and that was the labs and lifestyle. And then one day, I had a 16-year-old girl come in to see me who was depressed. And I said, well, we could, treat you with a medication or something like that. And the mom said, well, isn't there something more that we could do? And I said, well, yeah, well, of course there's more we could do. Maybe, why am I waiting for people? What rang in my mind is, why are we waiting for people to develop treatment-resistant depression to determine what are the causes of their depression?
Right.
So what I did was I did the whole lab workup on the 16-year-old, and I did genetic testing, and I found that and I looked at her lifestyle and her social psychological situation, and I found out that she had a genetic abnormality that predisposed to depression that's very easily treated with a supplement. I found out that she had mild hypothyroidism that you wouldn't have picked up on just regular thyroid testing, and that she was very sedentary and had some evidence of metabolic syndrome. And so I said, well, okay, so we could just treat these things and not do a medication and see how things go.
Yeah. So
we did that, and she came back in 6 weeks, 2 months later, and said, I'm fine. And in my mind, I thought, okay, if I had treated her with Prozac,
mm-hmm.
she might have gotten better.
Right.
And then she would go around the rest of her life, whenever she got depressed, thinking, oh, it's that Prozac problem, my Prozac deficiency syndrome, so I should take more Prozac.
Yeah. Up the dosage or increase it or take it during,
But now she I think is saying, well, what lifestyle changes should I be making? Have I stopped taking that supplement that fixes this genetic abnormality that I've got? Are there some other things that I could do that would be much more benign than antidepressant medication?
Right.
And so it's interesting to be struck on the head, hit on the head, kicked in the head by something that you already know.
Right.
I mean, I already knew that we should do that, but I just wasn't doing it because I thought, well, it makes sense for treatment-resistant people. But then the question in my mind obviously was, what the aha moment was, but why are we doing this for everybody so they don't become treatment-resistant?
Right. Like, can we avoid that road that so many people go down? And I, as a therapist myself, I have people come in constantly saying, I'm scared to do that because I'm worried it's not going to work, or I'm worried about the side effects that might come with it, or for whatever reason, not realizing that maybe there's some other options that we can look at.
Yeah. Yeah.
I mean, how empowering for so many people to be able to do something like that and look at it differently.
Yeah. Yeah. No, it's been super rewarding, and you know, I can't tell you. I mean, for me, I do a lot of management and teaching and that kind of stuff within our clinics and that sort of thing. So I don't see that many patients anymore, but I do sometimes. And I once in a while will go in both of my clinics, both in Rapid City and in Minneapolis. I will, maybe check out the ketamine patients who, need to be checked out before they're done with their treatment. I'll go and just talk to them briefly, be sure everything's fine, ready to go. And it's just so common. I mean, I would say virtually every time I do it, there will be at least one person who will say, "Hmm, so you're Manlove." And I say, "Yeah, yeah, that's true." And so I see your name, on the the people who started this clinic, and
Yeah.
I say, "Yeah, yeah, yeah, that's I mean, and they say, if you didn't offer this, I would be dead."
Right.
And it's like, yeah, yeah, and I'm not sure it's quite that dramatic, but that's their experience of it, that
Right.
they may not have died, but they were suicidal and were miserable and were not living a life of meaning and hopefulness and positivity, so it's really exciting to be part of that and to help people move through these dark, dark times in their life. And there's so many people who are there, I mean, it's such a common problem, and there are treatments. And I wish we could say we treat everybody successfully. That's not the case,
Right.
but I can tell you that we try hard, and we don't abandon anybody.
Right.
We're going to do a full court press. Sometimes when you do the full court press, it doesn't work,
Yeah.
but very often it does. And like I say, 70 to 80% of those people who don't respond to other things are having a good response. So it's really, really, really cool, and a really important option for people to have available.
Absolutely. I also think too, these are the people that are able to come through your door too. I know that it's not that we're reaching everybody, but being able to reach as many as possible is huge. And I'm very thankful that you're doing this work and continuing to open the doors and offer different options for people. Which brings me to my next thing. When let's say someone's listening right now and they want to reach out to your office, what does that look like to be able to connect? Because like you said, it's not necessarily you going to be seeing them every time, right? You can't see all
Yeah,
clients.
yeah,
You're doing a lot of other things. So what does that look like?
yeah. So right now it looks a little chaotic because getting involved with a new electronic health record system.
Oh, yes.
But we're getting through it, and we are still doing our full spectrum of work. It's
Right.
we're hoping that people will kind of bear with us a little bit for a few weeks here. But no, what it looks like is people can go to our website and they can send us an email that you know engages with us, and we will respond back to them, or they can call us directly. They don't have to have referrals. We don't require referrals.
Okay. Good to know.
So people can come directly to us, or we're happy to have referrals also. And when they call, then what we would do is we would talk with them about things like insurances and how we would, it's just a business relationship that makes sense for them and us. And we take all commercial insurances in Minnesota. We haven't been able to work out financial agreements with the MA programs and the Medicare Advantage plans to afford to work with those folks.
Okay.
We do Medicare
Okay.
and some Medicare Advantage plans that pay Medicare rates. We have to unfortunately make enough money to pay for our staffing.
Right.
and our overhead. But most insurances we take, there are some of those that we don't take. So we find that out, and then we just be sure that they're looking for something that we might be able to help, and then we schedule them. We try to schedule people the day that they call for an appointment as soon as possible, and we can usually get people in within a week. We try to keep our staffing levels up so we can get people in quickly, and
Wonderful.
and that means the clinicians who see them are mostly nurse practitioners and PAs, and there's another or a psychiatrist who they're working together as a team. So the NPs and the PAs who we work with are trained by Dr. Johns and myself and work with us closely. I feel comfortable that they are getting what I would give them. The patients are getting what I would give them if they see one of those people.
Yeah.
Because I'm involved with them and Dr. Johns is involved with them on a regular basis, and we've worked with them, especially when they start. We're working very closely with them. So that is mostly who they see. Mostly they do not see me because there's just not enough bandwidth in my life to be seeing a lot of patients right now.
Right.
But I try to stay engaged with the process, and I think I'm doing that reasonably well.
Wonderful. So for those who would want to, do you also offer private pay options?
We do offer private pay options. Yes.
Okay.
So
because I know
instance,
sometimes different things, depending on insurance, whether they cover certain services or not, or if they want to, hey, I've dealt with depression, but maybe it doesn't qualify me for treatment resistant, those kinds of options for different things.
Yeah, and to clarify that a little bit more, most insurances cover transcranial magnetic stimulation these days. Most insurances do not cover ketamine.
Right.
So it's important to understand that. Most insurances do cover Spravato, which is an intranasal form of what essentially is ketamine. So there's generally pretty good insurance coverage for transcranial magnetic stimulation and Spravato. Somewhat variable, but in general, that is the case. Most insurances do cover the clinical piece, the evaluations and follow-ups that they do with clinicians in our office. And we've really worked on making this accessible to the average person because there's a lot of average people who have depression. I don't want to only treat people who have enough to pay out of their pocket.
Right. I mean, that is a huge barrier for care, as we know, and it gets very tricky because, like you said, I still need to be able to pay my staff and to be able to keep the lights on to provide the services, and I want to make sure that the average person can receive services because we all deserve that, right?
Yeah, it's a discussion we have continuously in the office, and we do our best. I mean, it's an interesting thing running a few businesses that are at this point moderately large, and then being a clinician at the same time, because your heart's got to be in two different spots.
They don't always work well together. Those two aspects of things, it can be very difficult.
Yeah, and if there weren't tension there, I would maybe be concerned about where my brain was too.
Right. No, absolutely. And there's a lot of challenges in mental health in general right now. So I'm very thankful that you can provide these options and you are seeing such success. I also wanted to ask you, is there something that stands out to you in your job or your field that you kind of want to debunk? Because I know we've talked about a lot of clarifications, but is there something specific that you find you want to say, I want to debunk this about my job?
Gosh, there are so many preconceived notions of what psychiatrists are like.
Yes.
I think the biggest, essentially my purpose, my mission as a psychiatrist is to tell people a couple of things. One is there are other options besides what the pharmaceutical industry has to offer. And I'm not saying that they don't offer good things. They do, and I use them all the time. So but there are other very, very good options.
Yes.
And so don't get stuck just because the person you're seeing doesn't believe that these other things work. I'm telling you, TMS and ketamine work well. They're well studied,
Yes.
and they are very safe. I mean, nothing is completely safe, but they are as safe as any medication that is offered in the pharmaceutical compendium. When they're done right, when they're used correctly. A second one is related to that. With ketamine, it should be done correctly. It's not safe if it's done in your home by yourself or without the right level of supervision. I think it can be very dangerous. So I'm on a little bit of a mission to help people understand that, because I've seen some bad outcomes in those kinds of settings. Not every time by any means, but I think it should be done in a monitored setting,
Yeah.
ketamine and Spravato. And
Yeah.
by the way, the FDA agrees with me on that. With Spravato, and I believe what they're talking about with Spravato applies equally well to ketamine. The third thing is that depression is a biological illness. It is an interesting and complex biological illness because it is affected by environment, interpersonal relationships, what we eat, what we do, all those kinds of things. But ultimately, there are changes in the brain that are causing depression. If you do a functional MRI scan on the brain of a person who's depressed, and you compare that to people who aren't depressed, it is as different as looking at a broken arm and looking at my arm on an X-ray.
Yes.
There's very clear differences.
Yes.
So if you have depression, it's not a moral shortcoming. It's not a lack of will. It's not a lack of personal strength. It's an illness that can be treated. And then lastly, the way to treat it is not just to treat the symptoms, but to look at a bigger version of yourself. You are more than depression. You're more than ADHD. You're more than bipolar disorder. You are a person there's lots of things that you're doing, lots of interfaces with you, and lots of things are going on biologically and genetically inside of you that are interfacing, that are causing this, what we call illness, to come out. And if we can define those things well, we have a much better chance of treating you well.
Yes.
So don't accept that because I'm depressed, the only way to treat this is with an antidepressant. It may be a good tool,
Right.
but there are other things to think about. I feel like as a society, we are saying too much. If I don't feel good, I should take a drug.
Right. And that's it.
Yeah, that's it. And that might be even a street drug. If I'm not happy, I should take either a prescribed drug or a street drug. And unfortunately, that doesn't really get at the cause of unhappiness.
No. It doesn't last either. Right? Like you said, prescriptions, things like that can be a great tool on the road of healing. But I always tell people, like you said, the brain is an organ. It's another part of your body. It gets damaged. It can need help, just like a broken arm, and when you look at it differently that way, it takes a lot of the shame and the guilt that keep people in that state as well.
Well, one other thing I just want to mention, because I think that you may have psychotherapists who are listening to your podcast, and that is that I think that treating depression in whatever way it happens can be a fantastic augmentation agent for psychotherapy.
Yeah.
I mean, I do psychotherapy myself also. And I've had people stuck for years before I was doing some of these things who, when we treated effectively, then all of a sudden their psychotherapy took off. They were able to make changes, able to make lifestyle changes, able to think through problems that they just hadn't been able to sort through because of their depression. So it really augments psychotherapy. And by the way, we very strongly encourage people to be doing psychotherapy in conjunction with these treatments. Because
I was just going to ask you that, because as a therapist myself, I had just started to understand a little bit more of the research behind TMS, ketamine, and things like that. When I started asking the questions, it did really push towards yes. And when you pair them with therapy, I know for me, I specialize in EMDR therapy, and the research on EMDR and ketamine and EMDR and TMS, they're both helping that neuroplasticity. They're both increasing that ability, and the success rates are huge when you put them together.
Right. So the neuroplasticity issue, most psychiatric problems and most neurological problems in general, it's becoming more and more clear are problems related to neuroplasticity. Either atrophic or hypertrophic parts of the brain related to either some illness or a genetic problem or biological issues. And whenever we help people with depression, you see improved neuroplasticity.
I'm so excited about these different treatments that are available, and I'm excited to see how they have taken off and how they'll continue to take off as we get more and more into the research and more people are offering this. So thank you so much for answering those, debunking all of those things, clarifying how to get in contact with your office. I am so thrilled to have you. Is there anything else that you want to leave our listeners with today?
We have a website for our clinic in Golden Valley. Is called Advanced Brain and Body Clinic. So if you go to advancedbrainbody.com, it will get you to our website. We have a lot of information there. And I've done we've written several articles about what we're doing that would give people more information. And it's also an easy way to access our clinic if people are interested.
Perfect. Again, I'll make sure to link all of those below. Check it out. I have read some of those blog articles. They're fascinating. And it really just points to some really good information that's out there. Thank you again so much.
Yep. Thanks. Appreciate it. Have a great day.
You too.
Thank you for inviting me. It's
been a pleasure.
Yeah. Okay. Yep. Take care.
All right, guys, this is the legal stuff, the disclaimer. The podcast is intended for educational purposes only. The information provided is not a substitute for professional therapeutic advice or counseling. Always consult with a qualified mental health professional for any personal concerns or issues. The views expressed on this podcast are those of the host and guest and do not represent the views of any affiliated institution or organization. Listener discretion is advised.